Well, welcome everyone to this session. It's a pleasure to be with you all today on screening and diagnosis of inherited blood disorders, opportunities for cross-country collaborations. We have quite a number of experts here to speak to their work, and we look forward to further dialogue and discussion, especially from those who are participating today. We'll have some time towards the end for more discussion, so please make sure to use the chat feature, either through the online platform if you're calling in via Zoom. Feel free to use the Q&A or the chat buttons as well, and we'll get to your question and discussion. For those who may not know, my name is Andrew Zapfel. I'm Manager of International Programs and Alliances at the American Society of Hematology. I'm very excited to moderate this panel today. Just to note, this call is being recorded, so this is to be shared later. I want to make sure everyone is aware of that. And again, as noted, we will have time at the end for any questions, and a survey will be provided towards the end because we want to hear your feedback on the session itself. But with that, I look forward to now our discussion, particularly on screening and diagnosis and ways that we've tried to find new ways of scaling up, as well as sustaining and building quality programs. With that, I'm going to pass it now to our first speaker, Dr. Teresa Kotzer, who will be speaking about the Consortium on Newborn Screening in Africa. Dr. Kotzer.
Well, good morning, good afternoon, good evening, everyone. It's a pleasure for me to be here, and I would like to thank the organizers for inviting me to chat to you about the Consortium on Newborn Screening in Africa, or CONSA. And I'd like to use CONSA as an example to illustrate how you can ensure quality laboratory work across several different African countries. So in terms of background, the Consortium on Newborn Screening is a network of 7 countries comprising 10 sites. And CONSA seeks to demonstrate the benefits of newborn screening and early interventions for children with sickle cell disease in sub-Saharan Africa. And CONSA is financially supported by the American Society of Hematology. The main objectives of CONSA are to determine the population-based birth incidence of each of the CONSA countries of SCD, and secondly, to evaluate the effectiveness of early standardized care in preventing early mortality in children with SCD. Because as is commonly known, a child in Africa with SCD has a much higher chance of dying before he or she reaches the age of 5 compared to a child in the US with sickle cell disease. And then CONSA will also evaluate the long-term sustainability of the program, because we're hoping that the CONSA initiative can form a nucleus that will subsequently spread out into a countrywide program of screening and early intervention. So these are the countries that are currently part of CONSA. In West Africa, we have Nigeria, Ghana, Liberia, and in East Africa, we have Kenya, Uganda, Tanzania, and Zambia. So each CONSA country has a layered organizational structure. We start with a national coordinator, and even if there are 2 sites in a country, there's only one national coordinator who provides oversight and leadership. Then we have the nurses at clinics and hospitals. They collect the dried blood spots from newborns via a heel prick, and they also follow up with the mothers who have SCD babies. We then have the laboratory staff at a single central lab facility, and the lab staff diagnose SCD in the babies using isoelectric focusing gels, or IEF. We also have a data manager for each country, as well as data clerks, and these individuals manage the data on the central ASH data hub. So there's a central electronic repository of all the data from all the different countries, and that's an important point of CONSA. Then finally, we have clinicians and nurses who provide the clinical care and follow-up of babies and ensure that they attend the clinics regularly and that they get all the preventative interventions to ensure that they can have a better and hopefully longer life. The governance structure of CONSA consists of an overarching steering committee, and below that we have several subcommittees, as you can see in these different boxes. but I'm going to focus on the Laboratory and Diagnostics Subcommittee. So this subcommittee is co-chaired by myself, and I'm from the University of the Witwatersrand in Johannesburg in South Africa, and Dr. Russell Ware from Cincinnati Children's Hospital in the US is my co-chair, and Dr. Ware is very well known in the SCD field. So what is the role of the Laboratory and the Diagnostics Subcommittee? Well, firstly, it's to establish laboratory capacity. Secondly, to establish quality assurance procedures. And then finally, to ensure accurate diagnostic results on newborn samples. Because an accurate diagnosis of SCD babies is critical to the success of the whole CONSA initiative. So how do we achieve our goals? Well, firstly, the national coordinator in each country recruited laboratory staff, and equipment, reagents, and consumables were supplied by a partnership of ASH with PerkinElmer, which is now known as Revity. The second phase was training. So the nurses were trained to prepare DBS using heel pricks from newborns. The lab staff were trained to run and also interpret the IEF gels, and the data managers and data clerks were trained. The next phase was where we developed CONSA standard operating procedures, and standardization is a big feature of CONSA. So we utilize commercial controls on each IEF gel, and we ensure that there's ongoing implementation of quality assurance procedures. So let's have a brief look at the diagnostic laboratory procedures. Well, the nurses take a heel prick from each baby and they prepare a DBS. These are delivered to the lab. The lab staff then elute the hemoglobin from the DBS. They run samples and controls on IEF gels. And then they identify babies who are normal, who have trait, and who have sickle cell disease. And the photographs of the gels and the results are all uploaded on the ASH Data Hub. So again, there's a permanent electronic record of all the data that's been generated by all the different countries. This is an example of an isoelectric focusing gel. Can people see my cursor? Okay, so in terms of quality control, if we look at the control, which is shown here, we have hemoglobin A, hemoglobin F, hemoglobin S, and hemoglobin C. So all these bands are clearly separated. The sample is not overloaded, and there's very good separation between the A and the F bands. On the gel, we have 3 samples who have trait. And if we look at this one, for example, so this baby has hemoglobin F, hemoglobin A, which is the normal hemoglobin, as well as sickle hemoglobin. So this baby is a carrier and has trait. On the gel, there are also 2 sickle cell disease samples, and these babies only have hemoglobin F and hemoglobin S. They don't have any hemoglobin A. So they have sickle cell disease. So how do we ensure accurate diagnostic results across all the different countries and the sites? So standardization is an important concept. So all the sites have the same MyGel equipment to run IEF gels. They all use the same reagent kits. The same commercial controls are run on each IEF gel with samples, and all sites have standardized CONSA SOP. So all IEF gels are interpreted by 2 laboratory staff members. So this is to enhance the accuracy. So it's not just one individual looking at the gel and saying this baby has SCD or not. The 2 lab staff interpreting the gel really makes a difference. We also have stringent criteria for diagnosis of SCD babies. So all the newborn SCD samples are repeated to verify the result. So the lab staff will take a second punch from the DBS that came from the newborn. They'll run the IEF gel. And if the result again shows that this baby has SCD, the relevant nurse will be contacted, and he or she will then contact the mother and ask the mother to bring the SCD baby to the clinic. Now, at the first clinical visit of the SCD baby, a new DBS is prepared, and a confirmatory test is performed. If this confirmatory test is also positive, then the baby clearly has SCD and he or she is enrolled in the CONSA clinical program, which provides regular visits and preventative intervention measures. So there's also CONSA oversight to ensure diagnostic quality. So the Lab and Diagnostics Subcommittee has implemented several quality control procedures. But first of all, we have gel review. So this is where Dr. Ware and I review the gel photos and the results from each site. We then discuss findings with each site on individual Zoom calls. We prepare reports for each site. We email these reports to them, and we then evaluate the corrective action and feedback from the lab staff. What we've also done is we've asked the lab staff to re-evaluate all the older gels, simply to make sure that each baby with SCD has been accurately diagnosed and that we haven't missed any of these babies. Another important point is site visits, and this is really critical to the success of ensuring diagnostic quality. So what happens here is either Dr. Ware or myself, or in some instances both of us, physically go and visit each of the sites. We go to the lab, we meet the lab staff, we have a look and we assess how things are running in the lab. We see if they have any challenges that they are facing and how we can assist with overcoming those challenges or those barriers. And the laboratory staff is always very appreciative of the fact that we've taken the time and effort to come and visit them and to see how they are performing all the tests. And it makes them feel that they are really an important part of CONSA. They certainly are. From my perspective and from Dr. Ware's perspective, it provides us insight into how each lab is functioning. Because as is well known, the labs in Africa are not necessarily up to the same standard as you would have in the US, for example, or in Europe. So by us seeing the local circumstances under which the lab staff have to perform is really valuable so that we can appreciate any constraints or challenges that they may have. Then we also do refresher training, and this training also serves to empower the laboratory staff participating in CONSA. So we had a refresher training course over 2 days in Ghana, and this happened last month, so in September 2023. 2 laboratory staff from each site attended in person. So this was great for networking among the laboratory staff from all the CONSA sites, because none of these staff members knew each other because they all work in different countries. And unfortunately, there is typically not funding for lab staff to attend conferences and meetings where they can network. So this was really a great opportunity for the staff to get to know each other. And they all realized they're all in the same boat. They have similar challenges and constraints. So it really created a sort of a bonding atmosphere for them, and it made them much more motivated. And they realized how important they are for the whole CONSA initiative. So during the training, there was interaction with Revity technical experts. Now, these were 2 ladies from Finland. And as you can see in the photograph, the 2 Finnish ladies are obviously on the left. And on the right, we have some of the CONSA participants. So during the 2 days, there was lots of hands-on refresher training on running IEF gels, as well as the accurate interpretation of results. And finally, there was quite a lot of discussion providing valuable tips and also assisting in troubleshooting. So in line with the theme of the GONSIT conference of the power of the collective, I'd like to illustrate how this can ensure a quality across all the different laboratories. So first of all, we have public-private partnerships. That's between ASH and Revity. And then importantly, we have standardization of all the procedures and all the reagents across all the sites. And that is really a key to ensure quality across all the different countries. Then we also have a single laboratory for screening all the DBS at each country site. And that also makes it easier to manage all the laboratory procedures and the laboratory staff. So CONSA has really created individual expert sites in newborn screening, which all work towards a common goal. So they all feel that they are part of something bigger, and that's a big motivating factor for them to carry on with this work. There's also networking between laboratory staff of all 7 CONSA countries, and this never used to exist. So CONSA has facilitated this inter-country collaboration, but there's also within each site. This has fostered collaboration of laboratory, administrative, and clinical staff. And this typically would normally not happen because these staff perform different functions, so they don't really meet and collaborate. But because CONSA has so many different layers, it has really facilitated collaboration and interaction of these different levels of staff within each site. And this is my final slide, and it shows the participants at the refresher training that was held in Ghana. You can see they're all happy and smiling. The training actually went very well. They all received certificates, and you can see they all have some of these colorful African scarves. So I think this picture just really epitomizes the essence of CONSA, which is teamwork across 7 African countries. So thank you very much for your attention.
Great. Thank you, Dr. Coetzer, for sharing. Definitely an overview of ensuring quality in newborn screening, which is so critical. And we'll talk more about that, I think, when we get to discussion. As a reminder to everyone listening in, definitely appreciate any questions you might have. We'll ensure to follow up with everyone. And you can feel free to use the Zoom link, or as well as you can use the question and answer via the Zoom link, or as well as the online platform. Thank you so much. With that now, I will pass it over to our next presenter, who I see is here, Dr. Lakshmanan Krishnamurthy. If you'd like to now share your slides.
So I was so thrilled to hear Dr. Coetzer's presentation and how far CONSA has come along. Kudos. Just in the spirit of sharing experiences across the world, I was asked to speak on how new diseases are included in newborn screening panel in the United States. But it also got me thinking about, how the newborn screening program is generally run and how it functions. Obviously, we all know that Dr. Robert Guthrie was really at the beginning of this, and established the newborn screening for PKU. And since then, every state and territory in the United States has a newborn screening program. 4 million babies are screened annually for at least 31 serious disorders, where pre-symptomatic screening allows for intervention that will prevent a serious outcome and provide the best healthy life possible. And about 12,000 newborns are diagnosed with a disorder on the newborn screening. What's interesting about this newborn screening in the US is newborn screening programs is a collaboration between the federal and state government. They are regulated and administered at the state level. And just like a lot of the federal structure of the United States, it allows this program also to be customized to fit the state's specific needs. The federal government is not lacking in its duty because it administers and adds to the recommended uniform screening panel. So when a state needs to make a change, they have a standard to refer to. And RUSP is a set of recommended conditions for which they have a validated the diagnostic test. And so currently, there are 35 conditions in the RUSP. That is in addition to the screening for hearing loss. States may also screen for other secondary conditions, which are serious diseases detectable at birth via newborn screening. And the state retains flexibility in which RUSP conditions and which secondary conditions are included. And how does the expansion work? So as new diagnostic tests and treatments are approved, Then the HRSA, the Health Resource Service Administration of the Department of Health and Human Services, is the first level of review of the evidence for the disease, for the rationale for testing, and the validity of the testing. And then the RUSP is modified. And the most recent was in January of 2023 for GAMT deficiency. Now, how does the expansion actually happen? So every state really looks at the newborn screening panel and then takes a look at its budget and the prevalence of the condition. Including a new test in a state's newborn screening panel can be quite time intensive. And so often it's rolled out as a pilot study, and a lot of people are involved in this pilot study, which may take a long time to complete. And I've served in state newborn screening committees. I've worked with colleagues who are on the committee, experts in the field, and a number of different people are involved in making the decision about this. So the Newborn Screening Advisory Committee typically has a geneticist, a laboratory staff member familiar with the state process, and then a parent of a patient with a disease that was discovered by newborn screening. It has both governmental and non-governmental members and meet at least once a year. And I think it's a great example of, in some way, a democratic application of a public health intervention with multiple inputs. Well, all of this only works if you can pay for it. So the newborn screening programs require funding. They require funding for operating costs. They require funding for laboratory equipment. Laboratory equipment are priced in such a way that the actual costs come when you get the consumables rather than buying the initial machine. And you need skilled personnel and the test. So for most newborn screening programs in the US, it comes from a fee assessed for conducting the screening. So the general principle is that state departments should be working independently to set newborn screening to meet the program's need and should not be dependent on yearly appropriation for state government. So the goal is for these to be self-sustaining. Now, once you do the newborn screening and you have these dried blood spots, these dried blood spots are actually a treasure trove of information because enough blood is collected to run the initial and secondary screens or conduct additional testing to meet state requirements. But it's there for not only a source of research data on the diseases covered, but for a whole host of other conditions. So that's another key part of it. You might use it for quality assurance, quality control, so you can decide which test to do for which disorder. You can use it to advance knowledge and tools for screening, development of new tests, and you could really use it for improving existing testing technology. You can also use it for clinical studies on the diseases themselves or to better understand other diseases, and can lead to new treatments because you have these patients that you have these large number of patients with samples available on them. The other interesting thing about the newborn screening program is how many eyes there are on the prize. For instance, the CDC, the Association of Public Health Laboratories, it serves as a liaison between public health laboratories and federal and international agencies. And they actually do quite a bit of training. The National Organization for Rare Disorders independently evaluates the state newborn screening programs based on what are the elements, the key elements that we talked about are available. And then at the apex in the Department of Health and Human Services, the Health Resource Service Administration is the Secretary of Health, the Secretary of Health and Human Services, as an advisory committee, and has a similar composition of both experts, laboratory, clinical, and community advocates to provide advice and recommendations to the Secretary of HHS on the development of newborn screening, technologies, policies, guidelines, and programs, and with the goal of reducing morbidity and mortality in newborn screenings who have or at risk for heritable disorders. This is not an exhaustive list of all the eyes on the prize, but it's a reflection of all the involvement at so many different levels to make this a successful program. I'm sorry that the font is somewhat small, but this is the current list for the recommended uniform screening panel, or RUSP. So to summarize, and I think that this is really key, that newborn screening is embedded in a public health programs. And that I think is key for newborn screening to be successful in the long run. Involvement of the federal and state governments and their collaboration is key. Not only the government, not only the experts, but also public and community-based organizations have a voice in this. Sustainable source of funding is key. And use of residual blood for different applications such as QI/QC research and improvement of care should be thought about in the beginning. So I'll stop there and thank you all for listening.
Thank you so much for that great overview of the U.S. programs on newborn screening and the oversight that goes into it, not just from governments at the national and local levels, but also how civil society plays a role. We'll definitely talk more about that. Thank you for that. We'll continue on now with our speakers. Next up, we'll have Dr. Dipti Jain share her perspectives.
Thank you for inviting me for this talk. And the topic given to me is screening and diagnosis of inherited blood disorders in India, and where do we stand today? Next slide, please. Though it is inherited blood disorders, I would be talking mainly about sickle cell disease in India. And this was the time in 1910 when James Herrick first observed sickle cell in a patient. Next slide. It was only in 1952 that sickle cell in India was reported by Lehman and Kudbesh. Next, please. Next slide. The next slide is the map of India, where you also see there are 17 states in India which has very high prevalence of sickle cell disease. And now our target is on these 17 states of India. And these are the estimated number of patients in sickle cell. They are all estimates. Nobody knows the real number. And we know that India is in the top 3 for number of sickle cell patients in the world. Next, please. Next slide. Now, this was a milestone, a historical statement this year in 2023. In the budget speech, the finance minister said that India aims to eliminate sickle cell disease by 2047. I think no other country has yet come out with such mission statements. And by this, we mean the incidence of disease will be reduced to a specific level. Nobody can eradicate or eliminate by 2047. And here the goal is, in the first 2 years, to screen at least 7 crore, that is 70 million people under the age of 40 years. 0 to 40 years is the target group, and a budget of 542 crores has been proposed by the National Health Mission for this massive exercise. I think this statement has made a change in the policies, and we have now many strategies which has been planned and which I'll be talking about now. Next, please. Next slide, please. It was like, since I started working on sickle cell disease in 1980s, we used to do sickling test, not even a slide test, and by which we would know only whether the child has sickle or not, whether it is a carrier or a homozygous, we were not able to tell. Then it came with solubility, and confirmation was with paper electrophoresis in the beginning. Then it came cellulose acetate, and now we have HPLC and many more confirmatory tests. Now the government of India has left it to the state, as I heard from my previous speaker, that the federal government leaves it to the state which approach to use. So we have two approach. for screening and diagnosis of sickle cell disease. And first one is one-step approach, where we are using point of care test, which is used also as a confirmatory test in the field. But this point of care test are coming up in large number, and they're all made in India and very cheap, I would say $50. But there has to be validification by our apex body, that is ICMR. So there are 8 tests today which are government approved, which can be used in the field. Many of the states have still using the two-step approach, that is mass screening using solubility test, the tube turbidity test, and if positive, then only we will do the confirmatory test, that is HPLC, capillary electrophoresis, cellulose acid, other test, confirmatory test, and depending on at which level we are doing the test, the confirmation will be done. Next slide, please. Next slide. Now, the next slide is showing, now this is, we cannot afford to miss thalassemia, diagnosed thalassemia with sickle, because around 10 to 20% of our patients are double heterozygous. They are sickle thal. So we use complete blood count, and we have a cutoff value for MCV and MCH to detect carriers. And if we have this cutoff value, then only we do HPLC for these patients. Next slide, please. The next slide, I think, is showing the antenatal screening. I think this is very important for control of sickle cell disease in India, because the pre-marriage counseling works, but it is not that effective. And from our experience, I think antenatal testing is the thing which may help us in controlling sickle cell disease and reach our mission aim. Every antenatal woman must, it's a rule now, every woman anywhere, whether in the primary health care or in the tertiary care, they must undergo testing for solubility or point of care or HPLC, whatever is available at that level. And if found positive, the partner is tested. And if he is also positive, then they are offered chorionic villi sampling if they are below 12 weeks of pregnancy, or amniocentesis. I think this is a new policy which has come in India in the last 2 months, and people are coming forward to do prenatal diagnosis. Next slide, please. The next slide is, I think, about the neonatal screening. Neonatal screening, we have options. Again, we have universal newborn screening and target. Next slide, please. And target newborn screening. By target, we mean selective babies who are born in tribal areas which have very high prevalence, or we do babies born to the mother who are sickle cell trait. So we are catching homozygous SS patients more. So, and the blood sample could be Hill prick, cord blood, and the technologies are, we have already discussed by the other speakers. And for us, newborn screening, I would say we have in India, the policy says first contact till in the first 90 days of birth. It is not like in first 28 days, though it's a misnomer, newborn or neonatal. We take it as first 90 days. We can, because they come for immunization, and that is the time also we can screen the baby for sickle cell disease. Next slide, please. And this is found to be feasible. We have done in different areas, and we have found that newborn screening is feasible even in the remotest area by taking it on a paper. We have already discussed that by the previous speakers. Next slide, please. These are the methods by which different places we are using the newborn screening. The next slide. It is feasible, but I think the challenge today for newborn screening is the follow-up of the patients. After diagnosing them, we need to have proper infrastructure to follow them up properly. Next slide, please. Yeah. Now, this is a map of India, which individual states and district screening were done at different time points and were used using different technology. And that is what we are going to do. We cannot follow one technology everywhere. The methodology is also variable, and the target screening from symptomatic individual to population screening. So this is the status today, which is available for the screening in India in the last 4 months. Next slide, please. Next slide. Yeah, this is what we have, sickle cell cards. They are unique in the sense that one can do genetic counseling using this card. I cannot go into the details, but they are such that there are 3 holes, and the 3 holes will tell you, can a male marry a female? Because many of the marriages are still arranged in India, and they do match their sickle status. So these are the cards available now. They have been available for last 3 months only. Next slide, please. Next slide. I think with all this, India is a vast country, and we all know majority of the population is at the base of the pyramid, and where we may not have expertise. So we have also made a, what should I say, a referral system, and also who is going to do what at what level. Like at community screening, school, primary health, the screening method would be solubility, and maybe it would be confirmed only by hemoglobin electrophoresis. Who will do that? A multipurpose worker can do that, or a lab technician. So at each level we have specific screening test, confirmatory test, and a person who would conduct that test. Next slide, please. Even with all this planning, I think we still have challenges. And as we go to the field and do screening for sickle cell disease, the major challenge which we find is convincing the people to come when we are normal. Why do we have to screen? So I think counseling awareness is a key before we go for screening. And also another problem which we face here is most of the patients who come for screening have received blood transfusion. Next slide, please. Have received blood transfusion before they come to us. So I think establishing a diagnosis becomes very difficult, because we are not able to do any test for next 3 months once they have received transfusion, and they are lost by that time. Following them is very difficult. In spite of having molecular diagnosis for prenatal, only 30% of the couple who are identified at risk will use the facility. I think I would stop here. There are many challenges, many questions. I'll be happy to answer. Thank you for patient hearing.
Great. Thank you so much for sharing. And it's quite incredible the amount of progress made in India from where you've been to creating such political will. I think we'll definitely want to hear more about that, because it's such a vital need to make sure that we can see sickle cell efforts and other hemoglobinopathies, or every effort, just be able to scale up. But we'll finish up with our last speaker, and then we have quite a few questions already coming in. As a reminder to everyone, please feel free to use the Q&A feature on the Zoom link, or use the online platform as well to ask any questions. I've been taking notes, and we'll make sure to get to as many as possible. But with now, I'll pass it to our last speaker, Dr. Aleyo Sopakan from Nigeria, to share their perspectives.
Thank you, Andrew. Thank you so much. And good evening from Nigeria and other panelists there. I think the presentations have been very exciting. Learning from what our colleagues are doing in other countries. So, and I hope my presentation will also we'll share our own experience. How we've worked together with our patient groups. So I'm going to share my screen now. I hope you'll be able to see my screen. I think it stays, yeah. Yes.
We can see your screen now.
All right, thank you. Yeah, of course, I've been asked to speak on government and patient organizations advancing hereditary blood disorders. Of course, when I looked at the topic that was given to me, I thought of, the topic and what was expected of me and all that. Of course, the truth is that the patient organizations have actually played a major role in advancing the cause of hereditary blood disorders control and management in my country. So, which I think other countries also can learn one or two things from. So, next slide. Let me see. I think let me move to presentation mode now.
Yes, thank you.
Yes. So for us, how it all began for us was that the control program which was created. Of course, we put our sickle cell disease control under the non-communicable diseases control program. And the program was established in 1989 to address the rising burden of NCD in Nigeria. And of course, the NCD in focus then were cardiovascular diseases, diabetes, cancer, sickle cell disease, and COPD. And as at that time, of course, the strategic plans of actions were drawn out for each of these prioritized diseases. However, there was no baseline information to rely upon except for WHO estimates for the control effort for this disease. But in 1990, the first survey was conducted to give a kind of insight to the level of NCD problem that the country has to contend with. Of course, it was found out that 25% of the adult population that fall within the sample frame were healthy carriers of sickle gene. And less than 1% were living with sickle cell disease as at that time, because majority of those that were born with these diseases died before their 50th birthday. The mortality then was quite huge. Maybe almost like 90% of them actually died. Greater than 80% of our population then did not know their genotype. So the country embarked on aggressive awareness campaign as a strategic measure to reduce marriage between two carriers of the disease. This was before the UN declaration of sickle cell disease as a disease of major public health importance in 2008. Of course, what we now know as a country, what do we know? We now know that we are the most endemic country in the world as of today, and we know that sickle cell is one of the 10 non-communicable diseases causing disability, morbidity, and mortality in our country. And it has also, it's one of the diseases that actually made Nigeria not to meet the Millennium Development Goals, because it affects goal 1, 2, 4, 5, and 6 then. And not much was done to address sickle cell disease as at that time. And also, we are also looking at it that we are doing everything to see that we are able to meet sustainable development goals by 2030. Because we know that when you look at goals 1, 3, 4, and 10, sickle cell disease is there. So, and in terms of the burden, like I said, we are the one that carries the highest burden of this disease globally. We are ahead of India and Congo DRC. Of course, the reports of WHO in 2015 estimate that we have 2% of our newborns in Nigeria were affected by sickle cell disease. And then in 2018, we conducted a national demographic and health survey, which showed that unlike before, we have 21% carrier status, and then we have the prevalence that is a little over 1% among the children below 5 years. So that tells you that, there has been some improvements, maybe in the management, to ensure that these children survive beyond their 50th birthday. Of course, what were the significance of all this? Obviously, the need for government to create an environment and a framework that will galvanize all efforts, resources, and support that could unleash rapid evidence-based intervention that the impacts and outcome could be measured. And then, of course, the need for an enduring partnership to address the huge challenge that the disease is confronted the country with. We also look at the need to fund identified evidence-based intervention to address this huge burden. And lastly, the need to encourage, engage, and work closely with those living with the disease itself and their organization where they actually exist. Because when we came in 2010 to actually focus on sickle cell disease, we hardly had a patient group because the majority of our people prefer to live under the shadow of this disease. They don't even want to talk about it. Nobody even wants to come out and identify with the disease that, I'm living with the disease. So, and then what do we think we should do? Of course, government's reason that a multilateral partnership approach should be adopted for the control of the disease and all other issues that surround the disease in Nigeria. And such include working with our country-level partners, line ministries, that's other ministries and department agencies, patient support groups, and other stakeholders to produce a policy and guideline for the prevention, control, and management of the disease. This includes technical support, of course, from WHO country office, the office of the Senior Special Advisor to the President on MDG, Sickle Cell Foundation of Nigeria, academia, many other partners. However, partners that are interested in sickle cell disease are just too few at that time to make meaningful impacts. But we are not deterred, government, from forging ahead with the national plan for the disease. Guidelines for the control were developed. Active steps were also taken to set up patient support group. In fact, government took that in that step, and it's part of the policy that we need to engage the people living with the disease, including even the parents of those living with this disease, the children that are born with the disease. So, and we took that active step, not passive now, to set up patient support groups along with the what do you call it, Center of Excellence, 6 zonal Center of Excellence that were established for newborn screening then, of course. So we did that, and then we started having more of this patient coming out to identify with the disease. But the question now is that, has this approach worked? The truth is, it actually worked, to be modest. And those efforts led to a flurry of bills being pushed at our Nigerian National Assembly by the patient group, some of which have actually had significant impact on the control effort, because we're able to bring out these people and let them see that they have rights. They have right to demand, for services sickle cell disease services and all that, and that governments owe them the responsibility to ensure that they get services also like every other people living with other diseases. And the patient support groups have also kept governments on our toes to be alive to our responsibility in addressing the challenges of sickle cell disease in the country, which has resulted in improved care and demand creation. That's why if you go to our health facilities across the country, not just the zonal centers of excellence, all the health care level. In Nigeria, we have 3 levels of healthcare. We have the primary, secondary, and tertiary. And if you visit any of them, they are able to provide some services for sickle cell disease. And then we have also have improved funding for interventions by the government, especially at the national level. Before now, we don't have that. In fact, at the time, there was no funding at all allocated to address sickle cell disease in Nigeria. But of course, with the effort of these patient support groups, a lot has been done. There is also improved visibility for the disease, and which has brought out many others out of the shadow of the disease to become advocates. We now have them, we use them as advocates for the disease, and it has also reduced misconception and culture of silence about the disease in Nigeria. We've also had improved research, development, knowledge sharing, and collaboration. And lastly, it has also provided an impetus for other inherited blood disorders, e.g. hemophilia, to have a voice in demanding for government attention at addressing the bleeding disorder. Currently, hemophilia has been added to the portfolio of prioritized NCD by the government of Nigeria. So, of course, while lessons learned from all this, the lessons, of course, we learned a lot of lessons from the approach that we have adopted, having to work with the patient group and maybe their parents and other partners, particularly the patient group. We realized that governments alone, and those of us even working for government, even those in academia, we cannot do it alone. We can't do it alone. The provision of an opportunity and enabling environment for the patient groups, and even the patient who have a multiplier effect or benefit for health system and health interventions. The patient support groups are indispensable in shaping thoughts, decisions, and addressing challenges of healthcare in the developing countries like ours. Patient support groups should do more in fostering and streamlining cooperation among themselves to bolster their relevance, harness their collective strength, and entrench their contribution to and drive the sickle cell disease agenda. So we realize that this is something that should be done in our country, and it will also be used in other developing countries. I'm not talking of maybe developing, and I think even developed countries too. They can learn 1 or 2 things from this, but for us in developing countries, I think a lot of things can be done, a lot of things can be achieved with patient groups. So having said that, I'd like to appreciate some of the patient support group, particularly Sickle Cell Support Society of Nigeria, some foundation, like Sickle Cell Foundation of Nigeria, Gene of Generation Foundation, SCARF, Hemophilia Foundation of Nigeria, for their immense role in pushing government to actually address the issue of inherited blood disorders in Nigeria and improve the quality of life of those living with the disease in Nigeria. Thank you so much. Thank you for your attention. Thank you.
Wonderful. Thank you so much for that presentation, and particularly very fascinating seeing how from sickle cell to hemophilia, really seeing some lessons learned there. All right, so we're at time now for some discussion and questions, and there's been a few questions that have been added already. So definitely for those who are listening in, this is a great time to share any questions you may have for the panelists. I'll get us started, and definitely while I may call on a certain panelist, these questions are for everyone, so feel free to share your inputs. Perhaps Dr. Kotzer, we could start with you. You know, the focus of this session is on cross-country collaborations, and probably one of the best ways we can collaborate is to make sure that future projects don't make the same challenges or face the same challenges we have. And so when thinking about Kanza, what would you suggest projects or stakeholders prioritize when planning or starting to implement newborn screening? What would you suggest to them they should really be prioritizing and thinking about before implementing a newborn screening program?
Well, I think there are lots of factors to consider. And I mean, if we look back at the lessons that we learned through CONSA, that it's not an easy process. Firstly, you do need funding, but you also need motivated people who are willing to actually participate and be part of the whole process. So for anyone starting out, as I said, yeah, I think you've got to choose the right people, and you've got to ensure that you at least have funding to start the whole thing rolling. And what we've done with CONSA, as I said, we also would like to ensure the sustainability. So right from the word go, each national coordinator was tasked to discuss with government, even a regional level or even at the national government level, to try and garner support and to raise awareness right from the word go. So I think those are important aspects to consider, that one shouldn't just try something in isolation in a small city or a village somewhere, for example, that one should look at the bigger picture and also see which initiatives are already running in that country and how they can maybe join forces with those, again, to use the power of the collective instead of starting up afresh. But as I said, I think looking at CONSA, there were lots of lessons that we learned. And I saw in the chat, there was a question, Andrew, if I may answer that why we chose IEF for the CONSA program. It certainly is cost. And also in terms of maintenance of the equipment, you know, the IEF equipment, especially the systems that Revity provide, are sort of minimal maintenance requirements and very robust. So they will certainly last for a long time. And on each gel, we use the big gels, so we can run 88 samples on one gel. 8 of those are controls, so we can run 80 DBS samples on one gel. The run takes like an hour and a half, so you can easily run more than one gel per day. So we haven't found that to be the limiting factor when we've looked at our program in screening. I don't know, Andrew, would you like to add anything to that?
No, I think that's wonderful. Thank you. So I think the next questions go to both our India and Nigeria colleagues here. And it looks like, you know, as you look to scale up screening and scale up the number of people who have access to testing, obviously that means you're going to have a larger population with sickle cell disease or other diseases. So how have you been able or been planning on ensuring follow-up plans can be implemented, follow-up care can be provided, and there's enough healthcare workers available to provide that care as you're going to start seeing a larger number of people living with the disease? It goes for either Dr. Jain or Dr. Sopagan, whoever wants to go first.
I think for India, it's a difficult task, but we have planned of follow-up, and because there is going to be sudden increase in the number of patients with sickle cell disease, which we are going to diagnose through screening. And what I discussed now was only the screening aspect, which this mission program Sickle India has planned. Similarly, we have planned for follow-up and networking, data collection, and also using the existing health programs, including sickle cell. We have 3 or 4 major existing programs in India going on, health programs. So including sickle cell in them, and how we are going to include. There are modules, there are trainings going on. I think the planning is being done for that. It has started with awareness. Let me tell you that. It has started with awareness and counseling and screening. And now the next part.
Andrew, for us in Nigeria, newborn screening is something that, let me say, we started as far back in 2011. Of course, it's like we'll say, it's still new to us. And recently, we just introduced point of care screening test. And before now, of course, we use solubility, HB electrophoresis or sickling test. So, of course, we just introduce a point of care screening test now. So that is one. And we have also developed a policy that says that point of care screening test will now be the initial screening test for sickle cell disease because of the issue we've been having with electrophoresis, sickling test, and what do you call it, solubility test, because like she said, we don't have the human resource in Nigeria. As you know, human resource for health in Nigeria is also very dicey. And but another step we have taken also, aside from what she said, that you create awareness, a lot of awareness creation about newborn screening, because it has to be accepted by the parents that, yes, we want our child to be screened. They have to accept that first. So we have to make sure that, and remember, Nigeria is a country with a lot of culture and different traditions. So we have to create awareness and make sure that, yeah, it is acceptable. We have done that. And I think all of them have seen the advantage of getting their children screened. Then the next thing is that we are pushing these services to the primary healthcare level, because we know that more children are delivered at that level of care. And we have also developed a policy document that is tax shifting and tax sharing these services with the healthcare providers at the lower level of care. And we also know that wherever, of course, remember, in a country like ours, a lot of children too are born outside the health system. They are not delivered within the health facilities. So but one thing that we have been able to do is to make sure that and that has been accepted to everybody, is that once these children are delivered, they bring them for maybe the first, second immunization or third. So we are also taking advantage of that, and we have also, review our immunization schedule and all those things. So you bring your child in for immunization, then we take advantage of that and screen these children. So I wish we think it's a way for us to be able to catch these children very early and enroll them for comprehensive healthcare. So these are the things that we have done. We have recently also developed a desk guide for those level of healthcare providers on newborn screening. We've just developed a desk guide for them so that they can use to make sure that these services are rendered at this level. Because the sickle cell issue in Nigeria is a very big issue for us. So we are deploying every strategies that we can to make sure that we bring it to the BRS minimum and ensure that a lot of these children actually survive beyond their 5th birthday. Thank you.
No, thank you so much for all of that. And maybe, so unfortunately, Dr. Krishnamurti, I know, is seeing some patients right now, kind of going back and forth. So we'll ask some questions when he's back. But Dr. Kotsar, we just talked a lot about Nigeria just now, and I know you've been traveling, you've had site visits in Tanzania and Kenya and elsewhere. And you mentioned earlier in your presentation about, limited resources. Maybe you could share a bit more on these countries and what you've seen and how they've been trying to manage their sickle cell diagnostics and then linkage to care.
Yeah, I think certainly limited resources is a major factor. And that's why the CONSA program is working so well, because ASH has really put a lot of money behind this to ensure that it's functioning properly. So obviously now initially we only have small sites, but we are hoping that it expands. Yeah, in Nigeria, I mean, it's a very tough problem. So the 2 sites that we have in Nigeria are in Abuja. It's Prof. Obi Nodu is the national coordinator. And we also have a site in Kaduna State. And Dr. Livingston Dogara is the person on the ground there. And certainly, I mean, it's a huge struggle, you know, to find staff and to keep them motivated. But funding is a big issue. And it's interesting now that Nigeria has started to say that, you know, they are going to use point of care, that they're going to try and make mandatory throughout the country, which will certainly help. But, you know, even point of care, I mean, all these tests do come with their own challenges. So, but lack of resources is certainly a main issue. But I think, you know, in Africa, we can be creative and just see how can we best make use of the available resources. Again, maybe in the power of the collective, to learn from others before each site or each setting makes the same mistakes, which can be very costly. But I think what is encouraging to me is that throughout Africa now, there's a lot more awareness that has been created with sickle cell disease. And I think a major issue is if we can raise awareness, especially with the parents, because as you mentioned, a big problem, a big concern is the fact that the mothers don't want to acknowledge, or the parents don't want to acknowledge that their baby has sickle cell disease. So especially initially when they don't have clinical symptoms, they say, why should I bring my baby for preventive early treatment? So that is a big constraint. The other thing that might not be related to resources, but it's just once these babies have been identified, how do you keep them coming back for their clinical visits? Because we have quite a big dropout. We have about 50% lost to follow-up. But then even after that baby has come for the first visit, there's even a drop down to the second and third visit. So that's another big challenge that we'll face, not only in Africa, but in India and everywhere else. How do you, if you offer a preventive program, which should cost much less than having to deal with these babies and children having to be hospitalized for painful crises. So, you know, how do you motivate the parents to tell them the importance of bringing their child, even when the baby looks healthy, but that the preventive treatment can really make a big difference?
Thank you. And I see Dr. Krishnamurti is rejoining. I'll give him a second to join, but maybe Dr. Jain, while we're thinking, you know, you brought up a lot about, you know, India and the political will that's come to achieving sickle cell elimination by 2047. I was just curious if you maybe want to share a bit of, you know, the work that was done to go from where you were years past to now having this major government initiative. Do you have any advice to other civil society or doctors or healthcare providers on how you saw India go from where it was to now really leading as a country efforts to address sickle cell disease?
I would also like input from Dr. Krishnamurti, because he has been a part of this for the last 1.5 decades. Let me tell you that for bringing. It was like one is the patients group, which have become very active. The patient relatives, the relatives of the patient were very strong in different parts. And this sickle cell disease is not seen in big cities like Bombay and Delhi, not in metros. In spite of that, the patients group was very strong. That was one thing. The other was the political will. Our Prime Minister comes from Gujarat. Gujarat is a state where the first sickle cell screening program was started in 1996. All schools, children were screened for sickle cell and thalassemia. So he was the one who had started all this in Gujarat. And when he became the prime minister, he continued to have this, and especially the tribal people. It's seen in tribal as well as non-tribal, but tribal are the underprivileged who are not accessible and other facilities. So making it available to the last mile, that was his main action. And they know now the morbidity with sickle cell disease and what is the burden with the government also with sickle cell disease. Lakshman, will you like to add something? Because you are muted.
Yep.
It's an amazing story, and one full of so much inspiration. When I first visited Dr. Jain at her clinic, and she called a bunch of patients just because I was there. And at the end of 2 hours, we all had tears running down our cheeks. So the power of one person. So there was an individual, Ranke, who reached out to young Dr. Jain and said, "You need to work on sickle cell disease." And so if you ask all the hundreds of ASH members who are from India, the vast majority have never seen a sickle cell patient when they were in India. So completely invisible disease in India if you were in Delhi or Mumbai and you were going to the United States from there. And Dr. Jain single-handedly started working on sickle cell disease despite no encouragement and complete discouragement, even from our own institution. And she built a program for 30 years. So I tell you, so there's a one person, another person. Yazdi Italia in Gujarat ran a blood bank, a private blood bank, and it was a biochemist. He got in to start screening for tribal. So tribal in India means Aboriginal tribes. And he got the whole idea of let's do the screening. And somehow he got connected with the chief minister of Gujarat, who happened to be Narendra Modi at the time, who realized that reaching out to this tribal population was somehow important politically or otherwise. And as he moved up to the center, he actually was able to leapfrog all kinds of awareness building, because when you build awareness in the top guy, then all the other people just fall in line. So amazing story. The scale is unbelievable. 30 million people have been already screened. Immense capacity. So I'm really excited, and it's a story of great inspiration for me. And in southern India, again, I've seen in Nandakumar Menon do this in a tribal community where the community owns the agenda. So it's an example at multiple levels, at an academic level, at a political level, and at a community level. All of these are great examples of how newborn screening and sickle cell care and hydroxyurea, et cetera, has advanced in India.
Thank you for that. And it's great to see, Ganson bringing together such amazing experts and advocates who have really led the way in their countries and globally, really, to make this a reality. Dr. Krishnamurti, while we have you, I think I'd love to ask you as well about, and Dr. Jain mentioned about patient organizations and civil society groups really advocating for this. And you mentioned in your presentation, the Association of Public Health Laboratories, National Organization of Rare Diseases, and their roles in overseeing and advocating. What advice would you give to organizations on how they could work in their countries to be a part of this quality oversight or be a part of developing these policies to ensure we can develop diagnostics and screenings for these rare disorders?
I would not be so impertinent as to advise anybody, because there are some great and wonderful people that I'm inspired by who are in the field doing this. From even in preparing this talk, I realized institutionalizing newborn screen, not as a one-off thing, not as a pilot thing, not just as a hospital thing, not just as a government thing, not just as an academic thing, not just as something that a community wants, but all of the above. I think that really is a message. And I've seen, I mean, Kansa, wow, it's just amazing how so many of things of that happen. So I'm really excited, what wonderful work's happening in Nigeria. But I think institutionalizing it completely, because COVID showed us that there are functioning public health systems in so many parts of the world, and they need to own sickle cell newborn screening.
Thank you. Seems like there's quite a lot of interest about Nigeria, actually. So maybe Dr. Sopakan, we'll go back to you. There's questions about, maybe I'll share two questions with you. One more of a statement first, and then we started newborn screening in Nigeria in 2010, and the PHCs need training to provide appropriate follow-up in the primary healthcare facilities. And what else the person wrote, the government hospital I visited verified that newborn screening is in all government hospitals in Nigeria. Is this true? So maybe you could share a bit about training of PHCs, as well as, the outreach and scale of newborn screening available right now. You're currently on mute.
Okay. Can you hear me now? Yeah, good. Yes, you see, like I told you before, in Nigeria, we have 3 levels of health care. The primary level of care is the closest to the community. And these health facilities were even distributed in a manner that you have one in each ward district, So, and then in all our tertiary level of care, of course, they provide services. They can manage sickle cell disease, but of course, the knowledge and the skill is not there at the lower level of care. So we have to start from there. We believe that if we were to institutionalize sickle cell, newborn screening, universal newborn screening. Remember, we adopted universal newborn screening policy for our country. So, and in institutionalizing that, it means we have to carry not just our colleagues in the clinics, or that is in the hospitals along, those of our colleagues who are in the academia, of course, or in the research institutes. But of course, we have to involve the patients themselves or their parents. And then we have to make sure that we create awareness, let them see the importance of getting these children screened in the first place. So, and we realize that because of the issue we have with the primary health care level, we need to start from there. And that's what informed the decision that we have to start from the primary health care level. Recently, we trained because we use information that are available to us. Like I said, we did a national demographic and health survey in 2018, and that gave us information that the southwest geopolitical zone of the country is having the highest prevalence or burden of the disease in Nigeria. So we had to start with them. So we started training of healthcare workers at the primary level of care in that zone. That was completed. We also did community mobilization and awareness creation on newborn screening. Of course, they are aware of the disease, but of course, this technology, particularly identifying these children very early, a lot of them, even many of the healthcare workers that came, I think it's only one person among them that said, yes, she has heard of newborn screening for sickle cell disease, but she has never seen it and she didn't know anything about it. I said, yes, you saw it and it was demonstrated to them. They are using the available point of care kits. And then we started receiving, feedback from some of them that were trained that, oh, this thing really worked. We've been able to identify some of these children, even some of them who have been sick and they've been in and out of the hospital, not knowing that they are actually having sickle cell disease. They've been able to identify them. So of course, we feel that when we were able to do this, and then there is a clear referral pathway that they can refer these children to those of them who are found to be positive. And of course, that is where we need to do a lot of work on the mothers or the parents of these kids or these children, because you also, now that you have identified these children, you also have to let them know the reason why you are enrolling these children for a long-term care, the comprehensive healthcare, because there are times, and once they don't know this, you are going to lose them to follow up. And then one of the reasons again is that we are concentrating on the lower level of care. The lower level of care are actually within the community. They know them. They know this patient. They know their household. They know everybody. So they can, even when they don't see them, they can easily go back and check on them. Unlike if you are to ask them to go to the tertiary level of care, the teaching hospitals, the specialist hospitals that is far, far away from them, which will also increase the burden of managing this disease on these parents, which will also increase your loss to follow-up cases. Because we know the truth is that the disease also, even if you are not poor, it tends to push the parent or the family into poverty. So you don't want to do anything that will increase their problem, the poverty, because we know that in Nigeria, our health services is based on out-of-pocket expenses. Our health insurance is just for those that are in the formal sector of our economy. So these are the things. That is why we are concentrating in that area. That even when you don't see them, they can. And then there's a clear referral. When you refer, then this patient should be sent back to these people at the lower level to continue to monitor and manage them there. And if there is any issue, then they can actually still refer them back to the physician at higher level to continue the management. Thank you.
Dr. Kotzer, go ahead.
Yeah, thanks, Andrew. I have a question for Dr. Jane. So, I mean, the target that the Prime Minister had set, it's a very ambitious target. How have you been finding, so in terms of screening couples and adults for sickle, has there been pushback from the individuals, or do they readily give their consent to be screened? And if they're both carriers, how do you proceed with the counseling, and how has that been received?
The counseling of premarital, I told you, of marriageable youth. We are screening schools, colleges, marriageable youths, and that part of counseling, they would do test, definitely, but the outcome of our counseling is not very good. While prenatal, over years, what I have seen, even this pre-marriage counseling has worked little better than what it was 20 years back. But what I'm seeing, great change in the prenatal diagnosis for sickle cell disease. People from remote places are coming to us to do prenatal diagnosis, especially if they have seen a child with SS, a child who is suffering. They would definitely come. And I think that is a big change which I'm seeing. And that is why I'm stressing so much on antenatal screening and prenatal diagnosis for India at least.
Thank you.
We're very close to the end. And so maybe just as a way of wrapping up this session, I'd love for all of our panelists maybe to share any final thoughts they'd like, just in terms of, the focus of the session was on cross-country collaborations and diagnostics. And so maybe just go around and say if there's any final thoughts you'd like to share with the attendees and each other before we conclude. No rush, anyone can go first, or I can call on you too. Maybe Dr.
Okay.
Kotzer, we'll go in order maybe.
Yeah. I think this session has been very informative, and I think we can learn lessons from each of the countries where we've heard presentations from. And I really think that, CONSA really shows how that collaboration between countries can work. Because I think with all the other presentations, it's been focused on one country. But what we've shown is that it is possible and it can be a success to do one program across different countries and to standardize everything. And I think if people feel that they are part of a bigger thing, not only in country or in their little city, if it's cross country, I think it has a lot of clout. But I think this session has been very informative, and I think there is hope for the way forward. We must just carry on. And yeah.
You, Dr. Krishnamurti?
Yeah, I'm so enthused by the progress that has been made worldwide. For a long time, it looked like, I don't know how this is going to work, but it's worked out quite spectacularly for all the reasons that we spent the last hour hearing. We all need to learn from each other, because I think that at least in the United States, greater involvement of advocates, advocacy, and community and academic organizations would be a big takeaway for me.
Thank you. Dr. Jain?
I think for me, this was really a learning experience, and it's going to help me in aiming our mission, what we have for elimination of sickle cell disease. And I think one thing, what I think has helped us is do whatever you can do with what you have. You can't have an ideal situation all the time, especially in a country like us and everywhere. Maybe there are pockets where there are center of excellence, but then there are places where you will not find, but do the best and really you can do and come up with the all of what our aim is to improve the quality of life of sickle cell patients and also control birth of a sickle cell patients. I think we can all do.
I'll end on Dr. Sobhagan. Before we go to you, I just want to remind everyone that the poll is now available, or remind everyone to please complete the poll for evaluating of this session. But with that, I'll pass it over to Dr. Sobhagan for final words.
Yeah, thank you so much. For us in Nigeria, we will, and I think other developing countries, we need to increase awareness and awareness creation. Genetic counseling is the key, and it should be voluntary. I mean, we have to find a way to make sure that, particularly in the developing countries, developing world, we have to make it, because people don't even want to know their genotype. So it is very, very key. It is very important. So we just have to find a way around it, making sure that we can create a more awareness, and then making sure that people voluntarily can go and, to find out what is my genotype. Because once we are able to do that, then people can take informed decisions in deciding who their partners should be. And even if, for instance, because like we are now seeing in the developing world that we have a lot of people, like in my country, that we have a lot of women giving birth to children. You don't know the couple, even when you don't know the spouse. Even when you ask, okay, where's the father? Perhaps you want to screen the husband or the partner. You can't identify the partner. So but once they know their own genotype, of course, if I'm going out with you, I can ask, do you know your genotype and all that, so we can be more careful. Yes, thank you so much.
Thank you. And I really do like doing the best you can with what you have, absolutely. And I know we're at the very end, so Dr. Jain, did you want to provide?
Yeah, I just wanted to say that what he said is very right. Awareness is the key to success. But then destigmatization, very important. I think when we do awareness or counseling, we have to take care of that. That is what I've learned in last 3 months when we started awareness.
So thank you all so much. Thank you for those who participated. And again, thank you, Gansett, for hosting. And I think we've learned so much. I've learned so much. And I think it's really great to see so many amazing advocates working to make sure that no matter where you are born, you should have access to diagnostics, treatment, and care. And let's make that a reality. So thank you all so much for your time. Enjoy the rest of your conference. I'm wishing everyone a great rest of your day and a great evening, especially those calling in quite late from around the world. So thank you so much.
Thank you.
Thanks, Andrew.
Thank you, everyone.